obligation. Thank you for that. Thankfully, the ethical codes change over time in response to how our society is changing, and that in turn then affects how our laws change, how our training changes, and then how we change. Next slide, please. Thank you so much. So each of us in here have our own separate professional ethics codes that we're required to follow. You know, there's folks in here that abide by social work codes and counseling codes and the medical profession. So it's really on us to understand our own principles of our ethics codes. We're going to know those codes to begin with, and then figure out how our personal values either fall in line with that or maybe sort of work against each other. So sometimes your values may not actually align with your professional ethics. Then what do you do? Who do you lean on to help you make that decision? Next slide, please. Because of how many different of us are in this group, there's really several ethical codes I could talk about. I'm going to end up referencing NADAC's Code of Ethics and the ACA Code of Ethics the most. So NADAC is the Association for Addiction Professionals, and then ACA is the American Counseling Association. Those are the folks I got to answer to, so that's who I'm going to end up talking about the most. I'll read NADAC's definition here. So ethics are generally regarded as the standards that govern the conduct of a person. Smith and Hodges define ethics as a human reflecting self-consciously on the act of being a moral being. This implies a process of self-reflection and awareness of how to behave as a moral being. Some definitions are dictated by law, individual belief systems, religion, or a mixture of all three. Now, one of the aspects of this definition I find to be challenging is that word moral, because so many things, including the laws that we abide by, our individual belief systems, and then our religious viewpoints can alter our perception about what we believe is moral. And I think a great example of this is abortion. Next slide, please. So when we're in the process of making that decision, we're going to hopefully get guidance from each of these tiers. So tier 1 is the federal level. That's the highest tier. That's going to include federal statutes that have to be carried out by all states. Tier 2 is the state level. This is informed by federal requirements, but can also include directives on how to carry out federal laws. Tier 3 is the licensure or credentialing level. So we have mandates from credentialing boards and professional organizations we got to abide by. Tier 4 is the agency level. There's going to be, rules and standards in an agency's policy and procedure manual that you're expected to follow. And tier 5 is that personal level. So each of us in here have our own internal ethical code and our own sort of internal set of morals, and that's created by our own personality, our own observations, and then our own life goals. Next slide, please. There's some things on here. Make sure if you want to just pop them up until there should be 3 bullet points on these slides, hopefully. Great, thank you. So what is an ethical dilemma? It's a challenging situation in which it's difficult to decide on the most appropriate or the most ethical course of action. So often in these dilemmas, you're going to have multiple ethical principles at odds with each other. And so to meet the need of one, you're going to have to compromise another one. And so in these situations, it's often difficult, if not impossible, to make the absolute right or correct decision. It's really about making the best decision that you can given the circumstances. So in this picture, my ethical dilemma was trying to get a shot of Spork wearing the SUD Echo colors, our buffalo plaid, but not wanting to. I see you repping it, Dr. Houston, thank you. But I also didn't want to interrupt his feeding time because it's very important to not do that. So that was my ethical dilemma. Thankfully, I was able to get to make it work somehow, and I still have all of my fingers and toes.
He looks great, by the way.
Doesn't he? Thank you so much. I'm very proud of that. You can, next slide, please. Thank you. So over the last year, and I'll be honest, I don't remember the dates of these. I mean, it was sometime last fall in our sort of part 1 of ethical dilemmas. We talked about boundaries, self-care, and telehealth. In part 2, we talked about how to treat multiple family members at the same agency. And then we also talked about what's our duty in regarding sort of scope of practice and then also advocacy. And so today we're going to talk about confidentiality as it relates to peer recovery support specialists, medical records, and then handling the death of a patient. Next slide. So let's first talk about the dynamics involved when you have a peer recovery support specialist on your team. So as more of us, as more of our agencies are blessed with the opportunity to work with peer recovery support specialists, also called peer recovery coaches, we're really at the same time learning how to manage those dual relationships that end up popping up. So Jennifer Boyd, thank you, Jennifer, if you're on the call, she gave me a great example of how a dilemma can pop up with this relationship. So she asked on her email, how should a peer recovery coach who is not a direct part of the treatment team, but has a close relationship with the team, handle it when a patient discloses a violation of program rules privately or in the setting of a support group? Violations like persistent relapses or falsifying a urine screen. How can the coach remain true to the program and the patient? So Jennifer, great suggestion. Thank you so much for bringing this up. In terms of our ethical codes, we could really look at this as a dilemma of honoring the confidentiality of the patient and then also the safety of the patient. So in West Virginia, our peer coaches are asked to abide by the NADAC NCC AP National Certified Peer Recovery Support Specialist Code of Ethics. I know it's a long statement. That code itself isn't as detailed. It's not as detailed as the regular NADAC Code of Ethics that the counselors follow, and it's a little bit broad about requirements. However, within that code, the coaches are essentially instructed to abide by their agency policies. And so if you remember, if we talked about the tiers earlier, what you want to do is follow the guidelines of the more stringent tier. So just so you all know, within our agency at WVU Medicine, our agency policy is that our peers are a liaison between the treatment team and the community. But we want to make sure they're adhering to the confidentiality that is a hallmark of the peer recovery group community. So we want our patients to know that what they're sharing in a peer support group meeting or with other peer support members is going to be kept confidential. So for us, it's our expectation that the peer recovery coach is going to keep confidential what patients are sharing with them. They're going to also, along the way, talk to the patient directly and encourage them to disclose things to the treatment team, knowing that that might take multiple conversations. And if a peer is worried about that patient's safety, potentially due to what the patient's doing, maybe what they're relapsing on, then they can talk with their team about that case in general, not disclosing the patient yet, and not disclosing any of their information, and really then determine the next best step. So that's how we handle things with peer recovery coaches and those dual relationships. I'll open it up to you all. Have you all do you sort of handle those dual relationships differently? How is it working with the agencies that do get to work with peers? Anybody else handle that differently?
Feel free to unmute or chat in, and I can read the chat out loud.
Oh, that's good, because I always sometimes I have a hard time seeing the chat box when I'm
I got you, Katie.
Thank you, dear. Thank you. Well, I'm going to take the silence as that means that folks really handle those relationships the same way. So I'm going to take that as a win. Great. Okay, next slide. So let's talk about medical records. Let's talk about the dilemmas that pop up for our patients and their records. One of the questions I got is, what should we do when a patient requests for their entire medical record to be released to CPS or a probation officer or a lawyer? So again, if we're looking back to the Code of Ethics in terms of our codes, we could look at this as the dilemma of honoring the confidentiality of the patient as well as honoring client welfare. So according to the NADAC Code 11-9, it says addiction professionals who were ordered to release confidential and/or privileged information by a court shall obtain written informed consent from the client, shall take steps to prohibit the disclosure, or shall have the disclosure limited as narrowly as possible because of potential harm to the client or counseling the relationship. So for us, the first thing we always want to do first is to reach out to the client ahead of time if they didn't submit it to you directly. Sometimes a patient is submitting that release of information straight to you. For us at WVU Medicine, it actually goes to a separate office, and oftentimes what's hearing is we're hearing back from that office. They'll say, so-and-so, Jeremy's requested for his record to go to this person, but we didn't get a chance to talk with the patient. I cannot tell you how many times I have contacted a patient after I received one of those requests, only to find out that the patient either didn't need or actually didn't want their whole medical record sent out. They either felt pressured to do so, pressured from this other entity that's asking for it, or they weren't exactly clear on what they were signing. It has happened enough to know that that's really our department's goal. Anytime we get a request from a patient that's through our code program, the number one thing I'm always going to try to do is reach out to the patient to get really clear what it is they need. Because we've also unfortunately seen it happen too many times the wrong way. Another entity gets their whole medical record and they end up sort of using it against them in one form or another. And so according to the ACA Code of Ethics under the client welfare section, they will say that it's really on us to quote unquote safeguard the documentation necessary for rendering professional services. It's also on us under the roles at societal levels to advocate for their needs and to work towards removing barriers from them for accessing treatment. So again, we want to talk with the patient about what options they have. A lot of times I'm able to convince the entity that they don't need the patient's entire medical record. Really just what they need is a treatment letter. Hey, Hunter's coming to his appointments and he's being compliant with the program, and reach out if you need anything else. Almost always they're like, oh, that's really good. That's what I needed. I didn't need the patient's entire medical record. And so I think oftentimes that compromise can be agreed upon when we can give them a call. I'll turn it back over to you all. How have you handled this situation? Are there different things that you do in your agencies with your patients?
I was going to say, I really appreciate when you send those messages via Epic, Katie, whenever we get those requests, because a lot of times, like you said, they don't want actually everything to send out to certain things. So they're kind of confused about the process. So that clarification helps a lot.
Yeah. Oh, I'm glad that's helpful, Jordan. Thank you.
Yeah. And Katie, it may be better that is this, in our systems that we look at, maybe what you're describing should be the default, when people are asking, because it is pretty easy, it goes through lots of people. It doesn't always go to us, or we're busy, all those things. But if we had a default that said, they've been in the program for this long, they've been compliant, or even here are their drug screens, that's what they often want.
Yes.
And, kind of changing our consent form as opposed to, because it's really medically based. And I find it's particularly difficult when we're doing groups and in medical, we're doing code or M code in a medical setting, because it's not protected the same way your psychological counseling records. It's in your regular medical record, which I think is really important for the care of the patient, but it puts them at risk with law enforcement and legal. So it would be great if we changed our consent for this to for substance abuse treatment, mental health treatment, that we present a letter as default, and then if they need more, we go from there. I think that's a great idea, though. I don't always do that, and it's a problem.
Well, if you're like our providers here, David, you probably get multiple requests a day, and it's hard to keep track of them. And also we get messages where it's very like, you must respond to this in 7 days, and if you don't, it's automatically going to get sent out. I know I can feel a little rushed with that. So you make such a good point about where some of those are blended, especially with groups. We're trying to work on a more formal default. So that's currently not our formal process. It's just me trying to quickly grasp at those messages and get a message sent out that says, hey, I'm going to contact the patient before anybody releases it. Sometimes it's after the fact, but we're trying to work on a bit more of a formalized default route. If we are able to get that, I'll let you know. Thanks, David. That's helpful. Anybody else on this? Going once, twice. Okay, next slide. Thank you so much. Last one is handling the news of what happens when one of your patient dies, and specifically what happens when that patient is in your treatment and in your group treatment. So how do you handle the news of a patient death with their other group therapy members? Again, in terms of our ethical codes, we could look at this as the dilemma of honoring the confidentiality of that patient, but then also honoring the emotional needs of their other group members and working from a do no harm stance with them. This one's a lot trickier, and I'll sort of tell you ahead of time that this is one where we break the code sometimes. So on the one hand, if we're looking at counseling ethics, we have the code, it's 3.f, which is about deceased clients. And it says counselors protect the confidentiality of deceased clients consistent with legal requirements and the documented preferences of the client. On the other hand, if we go to the group work section, you have the code A.9.b, which is about protecting clients. And this one says, in a group setting, counselors take reasonable precautions to protect clients from physical, emotional, or psychological trauma. And so if we were to follow this code to a T, we would have to ask each of our patients on intake how they want us to handle the news of their death, and then have them sign a release to do so, which to me doesn't feel good. That does not feel therapeutic. To me, that just feels like a terrible way to introduce them to treatment. Hi, I'm Katie. It's nice to meet you. How do you want me to tell you about your future groups when you die? It just doesn't feel good. We don't do that. However, I am absolutely open to discussion from you all if that's something that you do or something that we should do. Ultimately, in our department, we've chosen to handle this as a case-by-case situation. So we take into account the current group dynamics of the patients that are in there. We take into account the relationship that patient has to the group members, and essentially the small town community that exists among our patients. Oftentimes, when we are getting ready to share that news with the group, some of the group members have already heard it. If we have a therapeutic relationship with the patient's family, sometimes we've reached out to them for, kind of permission or feedback. But more times than not, that's not the case. So again, I'll throw it out to you all. How have you handled this situation? What feels like a way to best honor the patient, but then also the group members that you have in there? What sort of fits right for your ethics?
So I know we had this very same case come up with a lady who was in groups weekly, actually doing very well. She was recovering from benzos, but then she died of COVID. Now for us, yeah. Oh my God, it was awful because she was doing so well. But fortunately for us, or unfortunately, her family posted on Facebook that she had died. So like the general public knew. So when we were in group, some of the group members already knew, and it felt really bad to kind of ignore it and say, she's not here, by the way, just skip over. So we said, let's have a few moments for her death. And that's all we said. No one asked how she died, anything like that. But I think it's because someone posted on Facebook. Now, what I had a ethical dilemma though, because another group member called me who was not in group that day, her regular group, and said, hey, I heard so-and-so died. Is that true, doc? Right? And so I was like, oh, well, I'm pretty sure this is HIPAA if I answer him, because he's not, he's been in a group, but not recently. So I did say, according to Facebook posts, that is true. And we had some time over that, but I was like, man, I hope I'm not doing something wrong.
Dina, so first of all, Dina, I'm so sorry for the loss of that patient. That's hard. That's often how we have taken into account whether to make that decision too. Is it already public knowledge somewhere? Has it been posted on public profiles and social media? Is there an obituary attached to it? Are they gonna hear that from elsewhere? So that's a really good point.
And that's how we've handled the fine line too. If it's an obituary, anything in the obituary is free game, but as medical professionals and counseling professionals, we often have other insight that we can't share. So that's tough, but you're right. It also, judging whether it's traumatic for the group, it's also, but we're all small communities. It's balancing all that. There's no good answer.
Yeah, exactly. David, I think your dog sounds like they're really disagreeing with your viewpoint.
Yes, they are.
That. Yeah. Yeah.
Give them some buffalo plaque.
Actually, that's the problem. They saw the pork, the little pig and they're just jealous. Your pig is way bigger than my dog's. My dogs weigh 9 pounds. So
well, tell them to avert their eyes because there's a dog wearing the buffalo plaid in a coming slide. So
ooh.
Anybody else thoughts or feedback on how you and your team and the agency have handled those tough situations? Or would you do it differently than how we do? Does anybody sort of have is that part of your consent process that you go over that with patients ahead of time?
I usually just let everybody know that it's none of their business and they should stop asking questions. No, I'm just
I don't think you do that at all, Derek.
There was a time where we had a group member that kind of worked her way into everybody else's hearts, and they all were very concerned about her because she was a lot older than everybody else and had other health issues. So at first, when it was, she wasn't in group anymore, it was a lot of the questions, what happened to her? Where's she
Yeah.
at? Is she okay?
Yeah.
And then when it became more public knowledge that she had passed away, most everybody's first question is, was it a relapse? Did she overdose? And all these different
Yeah.
things. And at that point, we were like, oh, let's just clarify that it was natural causes. We're not going to go into details of everything else, but just to kind of clear everybody else's minds of what actually happened with her.
Yeah.
More so just to ease those traumatic thoughts that were popping up with people.
Yeah. Oh, David Jett. So Derek, thank you so much. That's a great point. I loved how you said that. She worked her way into everybody's hearts. And for me, that's why I feel like we make that decision of sharing that news, because yes, we're not abiding by the code of confidentiality, but we are abiding by not doing harm to our other patients who care about that person. David, I did just see the chat box. David made a really good point. Similar things happen with incarceration. Yes, when a patient disappears from group, the other group members care about them. And sometimes their first thought is, oh my gosh, are they not here because something happened to them? Or are they still alive? And that's always a tough boundary to walk through. Of sometimes I'll have to say, I'll just want you to trust me when I say they are okay. They're just not in group right now, and they're not going to be for a little bit. But yeah, that one's tough too.
Hey, this is Laura.
Hello.
We had a patient who was actually no longer a patient. He had been discharged from group, but he had an overdose death. And
Sorry, Laura.
we were in very close contact with his mother. And he's one of those ones too, that he was just a group favorite.
Yeah.
And so I actually conversed with his mom, and she gave me permission to share details with the group.
Okay.
So.
Laura, that tells me how much that family valued you and the work that you did with their kid, that they kept in touch with you and also cared about the work that can take place in a group.
Yeah. And I mean, it was a situation that was definitely hard to share, but I think it was eye-opening for a lot of group members.
Yeah. Yeah, that's a really good point. Thanks for sharing that, Laura. Anybody else, any additional thoughts or feedback on this?
Just one thing we've been working on with somebody else talk there, sorry. No, okay, anyway, sorry. One thing we're working on for some of our teleclinics is kind of taking care of yourself as well, as in addition to patients, obviously, is having I know we're trying to start like a debriefing group for one of our clinics.
Yeah.
So it's kind of taking care of ourselves in addition to patients, obviously, too. So
Yes, Jordan, thank you so much. Jordan's giving me a good plug for, I think when I present next in December, we're going to be talking about compassion fatigue, which is important every month, but especially as we're talking about this topic here. I think that's a great reminder, Jordan. Any other thoughts? Once, twice.
So we had here at Appalachian, we actually had a group member of ours pass away in a car accident last month. And it was right after group. So group would have ended and been done with around 2:30, something to 3. And then the accident happened at 4 that same day.
Oh, I'm so sorry.
So the next following week when they met, actually, Dr. Chandran is the one who opened the conversation by saying, this has taken place. And then Chris, our therapist, then took the lead on helping them discuss what their thoughts and feelings were attached with that, and processing the fact that they just sat in group with this person just last week, and then that person's no longer here. So
yeah. I'm so sorry you all had that experience, and so much gratitude to Chris and Dr. Chandran for taking on that task of participating in that kind of grief work with the patients. And it's an awful thing that happens. And sometimes some beautiful group work can take place from it, because it's people getting an opportunity to process that with each other. They may not have an opportunity to do that in other aspects of their life, have that kind of healthy group support system. But I'm sorry you guys had to go through that.
yeah, and Jordan has been working with us too, to get us, again, to take care. And but we have been, as an agency, also meeting and just talking, because the PRSS, myself, I did individual therapy, and then Chris did the group therapy, and then the case management worked with her weekly. And so we saw her every single week since last October. So it comes quick. So
It does. It does. Thank you guys for taking care of each other. And Jordan, thanks for helping them out. Okay. Next slide, please. We're almost done. So hopefully we've seen this model before. When we're faced with an ethical dilemma, we want to make sure that we get some guidance and support along the way, and a decision-making model can help do that. That there's not a specific name to this model. It's really just a culmination of steps from various models out there. So as you can see, there's a number of steps there. The first one is we want to make sure we're seeking out consultation. We don't want to have to make this kind of tough decision on our own. So this is the point of our agency team, our treatment team, the folks that we have in our life professionally to help us make this decision. We want to clearly define what's the ethical dilemma at hand. What are those different codes that are at odds with each other? We want to identify the ethical standards pertaining to the issue. We want to make sure we're checking in with what are our agency policies and then any potential legal issues related to that ethical issue we're dealing with. We want to make sure that we're honoring any cultural issues that are going on and sort of checking our own potential bias that we're bringing to it. Along the way, we're going to revise our definition as needed, get to the place where we can identify all the plausible options and look at them equally. And then we'll develop our appropriate response and, of course, document it as appropriate. And then next slide and final slide. My final message is I just want to remind you, as providers, we are going to make mistakes in this process because we're human. As providers, we want to try to help everybody we can, but we have to accept that that's not always going to be possible. As providers, we cannot know everything. We can't expect ourselves to know everything, which is why we continue this learning journey. Every single one of you showing up for ECHO, this is an example of that. And we cannot and should not do this work alone. We need the support of our colleagues and our peers in the field. And that's my farm mascot, Nellie, wearing our ECHO mascot colors, buffalo. And that's my. Oh yeah, when she sends these out, there'll be several like resource slides at the end of them.
Thank you so much, Katie.
Thank
That
you.
was so wonderful as always, and so touching hearing all the stories. So I appreciate you presenting on such an important topic, and all of you joining today and chiming in and sharing those stories. So thank you. Any questions or comments? Like Katie mentioned, I'll be sharing the slides in the recap email. You'll get all those wonderful resources. But feel free to unmute, chime in. Dr. Baltiera?
Yeah, so yeah, there we go. So Katie, quick question. We work in a lot of intraprofessional settings, psychologists, counselors, peers, physicians, nurses. Do you ever find any major conflicts in any of those codes of ethics? I mean, I haven't, but I was just curious if you'd run into that.
Yeah, great question. Thankfully, there's not any glaring differences. Laura Lander and I presented on ethics across the professions at ATI, I think last year. And we did the same thing. We were looking at them, trying to figure out like, where's the big discrepancies? And thankfully with the day-to-day work, they're all pretty much the same. The two areas where there seems to be differences, some of the codes have very strict rules about connecting to patients on social media and some don't. So the counseling ethics, you cannot be connected to a previous or former patient on social media. And actually the NADAC code is the same. There's a couple of professions that just don't have that included in there. And then interestingly, the one that's different is also having romantic relationships with former clients. Most of them say absolutely not, never ever. And I don't want to say the wrong one and then be wrong. One of them says you can after 5 years, but only if there's no other options. And essentially how the code is written. I don't know what no other options means. And I think it's psychologists, but please don't quote me if there's psychologists on here and I'm wrong. But those are really the only like major differences.
The ones we've come upon is more personal differences than professional.
Yeah.
And then another layer of it is when you work for a system, we all have our own. There's another whole code
Yeah.
social media, for example, for WV medicine and
Yeah.
stuff. So
Where we have, if I can call out in a positive way. So Sarah Lifeheight, one of our fantastic counselors, she's putting together for us a social impacts group. What she has talked about and other folks have talked about, hi dear, is for us clinical therapists, and I'm sure other professions on here, we're trying to figure out what's taking place in our culture, in our society. Where are our personal rules and values lining up with our ethical codes, and where is it not? You know, the idea, if we're thinking about social justice and all those movements, is there, you know, so if I'm pointing behind me, that's a ally, a piece of art that's meant to show my sort of allyship to the LGBTQ plus population. Some people would argue, based on your code of ethics, that you shouldn't have that in there. And some people would argue, absolutely, that's a part of just social justice, that you should have that in there. So to me, that's an area that I'm still trying to navigate. Where are my personal values coinciding with also what I think my ethical codes are, and are they potentially not in line with other people's codes in this building? So yeah, you asked a great question. Any other questions? Well, thanks for your time.
Thank you so much again, Katie. You did a wonderful job presenting, and you are wonderful at doing the echo pause for questions. So maybe we need to hire you for facilitating echo sessions as well. And thank you for putting all those photos of your farm animals. That is like one of my favorite things I always look forward to, and add the buffalo plaid. It's just the cherry on top.
I told Isra I was gonna do that, and like a month ago, I was like, I still need where do I get this blanket so I can take the photos? So
I would happily get like custom sized plaid like clothes for your farm animals. So let me know.
Well, they're all sharing that blanket now.
I love it. All right. Any final comments or questions before I go into announcements? Elizabeth just ordered some more plaid for the season. I love it. All righty. Well, thank you all so much. The only announcement I have, next session will be on September 26th, and Laura Lander will be presenting on SUD trigger strategies and preventing relapse. So keep an eye out for that reminder. We appreciate all of you. Derek, that makes me excited. Okay, it's awesome. That's great. All righty. Thanks, everyone. Have a wonderful rest of your day.